So, as I was thinking of coming here, I know that you're busy people with not much time, and I wanted to think of ways to have quick techniques. What are my best tips and tricks that I do to move forward with a patient? I know you have many, many, many patients, and you need to get as much moving forward as you can as quickly as possible. So we're going to talk about barriers to treatment, the concept of the therapist toolbox. I'd like to talk about some normal ways the brain works. And I also talk about 4 classes of therapist tools that I realized I used as I was making this talk. And we're going to talk about supportive therapy language. So it's a language that you can use, wordings that you can use that can help with a therapeutic alliance. So where I train, we think of the biopsychosocial formulation and the barriers to treatment. So biology can be genetics, the side effects related to genetics, drug addiction, medical conditions, pain, age. Psychological, trust, fear, resistance, psychosis, habit, past experiences and anxiety. And then everything else, social factors, maybe psychological too. But there's lots of places where we can find barriers to treatment. And patients will probably come up with some new ones that I didn't even put on here. So what is the way that we can break down this wall and get through to them quickly? So, some people have a good toolbox of psychological tools and instruments that they use. They may have 2 or 3 really good ones that are well trained and they use with confidence. Some people may have 1 tool, but it's really, really specialized. I'd like to just add tools, because as many tools as we have are different ways that we can meet different patients' needs. So in my toolbox, when I'm walking around rounds inpatient or in the emergency room, I have a stethoscope, I have a reflex hammer, my little flashlight to check pupils, and I've got my $1 million instrument. And it is worth every penny. This is better than the best computer out there. There is not a computer made that does what our brains do, yet. Maybe never. But this instrument can lose calibration if we're tired, if we had a fight with our spouse, if we didn't eat right, if we were on overnight call, if our car breaks down, or if the guy in the car next to you is having a bad day and says something rude as he drives by. There's lots of ways for our machine to lose calibration. So we talked about ways to keep it going. I think of these things that I do kind of in 4 classes. With patients, I like to educate them about the way their mind thinks, the way the mind normally does, and the way it changes after trauma in very predictable ways and actually normal ways. I like to use cognitive restructuring to flip the script. Sometimes I will turn things around backwards and look at them from that direction. We're going to try that. And I like to recognize and respond to unconscious transferences. That may not be something I say out loud to them, but it may be the way I respond. And techniques for working with moral injury and betrayal. So if you don't know to look for moral injury and betrayal, or if you don't know that that idea exists, it's really, really hard to work with it. So you guys are here learning that it exists or refining your knowledge a little bit. And it's important to teach the patients too that it exists. So this is actually a metal micro etching of a human brain slice that I have on the office of my wall in my office, called Self-Reflected in Violet by Greg Dunn. I thought this was really cool because I'm a nerd. But the human brain is beautiful. It's pretty remarkable. I think it's fascinating. We don't even begin to understand it yet fully yet. The brain is developed normally to remember danger, to see it where it's there, and to survive. I think that goes back to the beginning of time. And Elon might have said this earlier, because this is his slide that I took and I embellished a little. But fear is learned instantly. When something scary happens, we need to know it and remember it. And in the wild, practice makes perfect is not an option. And fear is remembered forever, for the most part. Maybe there could be some change to that. But generally, once you've learned it, it's there, and you got it. You're never going to forget that thing again. So remembering a dangerous situation is a normal function of the brain. We talk about PTSD as a disorder, but much of what goes on in the mind is normally how one would respond to a dangerous situation, to a traumatic situation. So I like to kind of think of it as it kind of helped us. So we have the fight, flight, or freeze response. So here's my little buddy, and he likes cookies. And there's some nice warm chocolate chip cookies there. And since my background is in reward and motivation, what gets people to get up and go toward an object? He's going to get up and go toward his cookies. But I imagine that can see the eyes. Yeah, sorry about the big giant growl there, but it serves a point. So there's a traumatic event. It's frightened. It's going to remember it. And in Pavlovian classical conditioning, we have an unconditioned stimulus of a big scary creature, and an unconditioned response of a fear response, fight or flight, activation of the HPA axis. But because we have these cookies here that previously were positive, valenced, he enjoyed them, they've now been associated in time with this scary event and have led to a conditioned response. So now when he sees the cookies, he gets the hair on the back of his neck to stand up and sick feeling in his stomach, and his pupils dilate because he gets fight or flight now with his new conditioned stimulus. This is a trigger, what we call a trigger for PTSD memories. So the things, the objects, places that remind us, they could be smells, it could be grandma's shampoo, actually could be a good memory, right? It could be jet fuel. It's one that gets me. I'm right back in the Army when I smell jet fuel, right? Because the olfactory bulb goes straight to the hippocampus. Could be lights, sirens, lots of things, even the friend that you were with that day. So does anybody know what the most common outcome is after a traumatic experience? Avoidance? Any other ideas? Overreaction? Anything else? Thank you, my friend. What do you think is the most common outcome? Fear, tremor. The most common reaction is recovery. 70% of the time we recover. Naturally. From our relationships, from our context, we recover. 30% or so remain residual into PTSD. That may be higher with repeated traumas, and that may be higher in the context of war. Okay? But the most common outcome of trauma is recovery. This is something that we have learned as humans for a long time, that we have these things happen, and we've got to deal with it. Factors that make trauma harder to treat. The severity of the stressor, a worse stressor. Physical injury associated with the stressor. The severity of the reaction. The greater the reaction initially, the greater the likelihood that it's harder to treat. The younger age at which it occurs, especially children, little children. Personal or family history, psychiatric history. Fewer social supports. Remember I talked about isolation? Past trauma or abuse. Gross disfigurement. That could be witnessing it or having it. And intentionally created by man. Did we talk about the car on the freeway and the boulder coming down? We did, right? So intentionally created by man, someone trying to hurt you. So here's a little technique that I like to use with the patients. I call it the Traumaometer. The Traumaometer, before we have trauma, goes from 0 to 100. It's a little needle that moves back and forth. How much anxiety or stress are you feeling? And once you have trauma, this is also a normal function of the brain. Once you have trauma, our Traumaometer resets. We have a broader range. You might hear patients say things like, you could only understand if you were there. I can only work with a military therapist who would get it. I can't unsee what I saw. I can't forget what I remember. And you don't have that experience. But it also increases our sense of capability. That I have been in a situation worse than this, and I survived, so I'm going to survive this one. I know what I'm capable of, and we haven't even gotten there yet. So I said this to our patients in COVID. I said to our vets, you have a really good skill that you know how to survive for a long period of time. In your home, your neighbors might not. I had one veteran tell me, 2 months of COVID lockdown, no big deal. I was in the desert for 2 years. Okay. So it gives us a different range, also a normal function. But it's helpful to see that your patients might be seeing things this way. I also like to talk to patients about the threat detector. That humans are really good threat detectors. I'm looking at all of you, and I'm going, do they like me? Who's on my side? Who looks mean? Who's angry at me? Am I okay? Y'all are a pretty good group. But we can take geometric objects in space, like a red line at an angle, a black dot, a blue circle, another black dot. And I'm looking at your faces and you're going like this. Where is she going with this? Because that's all they are, right? But if I change their configuration, I start to move things around. Come on now. It has a different meaning, right? I've activated a different set of neurons in your brain that are responsive to faces because we are threat detectors. We are going to look for faces. I can even change the valence of the emotion connected to your rostral cingulate by changing a curvature of a line or the orientation of the curvature or adding a couple more lines. Okay? So I've activated those neurons that are going to this association area to say, hey, watch out. I can even, well, all of us, we're so good at it, we can even find faces and things that don't have heads. I saw several of them here. I am so good at this, I can tell you their emotion. This one's surprised. This one's happy. This one needs more coffee. Right? So we're that good at attributing intention and emotion to things that don't even have faces. Now I'm going to ask you to take about 15 seconds of your precious time and look at these two faces for me. Just look at them. Now if I take an eye tracking device, put it over your face, watch where your eyes move to, and then track it on a monitor and map it. It's going to look something like this. Because you probably spent more time, I'm fascinated with the Rubik's Cube. Okay, it's okay. My kid has ADHD. You're going to spend more time looking at the threatening one, right? Because we're looking for danger signals. So you probably spent more time looking at that one, I would guess. Because we want to know who's friend or foe, who's going to help us and who's going to hurt us. It's really critical to survival, right? To know these things. So the threat detector leads our brains to develop a confirmatory bias. If I see threat, I'm more likely, or if I think there's threat, I'm more likely to find things that agree with that assumption. I'm going to find things that look scary. If I think you all are threatening, I'm going to find you ones out there that look scary to me. It's kind of a functional paranoia or functional suspiciousness. It may not be the same kind of paranoia as a delusional paranoia in schizophrenia, but it's a functional one. If people were shooting at me, if there were snipers and people blowing up explosives around me, it makes sense that I'm really suspicious and careful and look around. I may question my own judgment. Is this real or is this not real? Have I overestimated? Are you okay or are you not okay? And there's this exaggerated self-blame. Like, should I feel like this? I don't know if I should, if this is right or not. And it can lead to avoidance and isolation because I don't want to be around all these faces. I'm going to stay in my house. I'm going to hide. I don't want them looking at me. And it can lead to an overestimation of threat. I'm going to see threat where threat isn't necessarily so. So I talk to patients about being a threat detector. And what's your evaluation of that? And what did you see that frightened you? And is that real? Is that level of fear justified? But after trauma, our threat detectors are more sensitive because it keeps us alive. So if I look at you all and I say, you're scary people, and I make a guess that you're scary and you want to hurt me, and I'm right about that, I'm probably safe because I would have stayed away. And if I look at y'all and I say, you're really nice people, and I'm right about that, I'm okay. But if I say, you're really nice people, and I'm wrong, that's dangerous, right? I could get hurt, I could get killed. So it is safer for me to to make an error that skews toward assuming danger. If you're actually safe, and I assume you're dangerous and stay away, I'm still safe. The only one where I really get hurt is if I don't do this red one. It's safer to assume you're scary and have you not be. So your patients are not going to trust you. They're going to think you're going to hurt them. They're going to be afraid of the system. They're going to be afraid of their commands. There will be things that will happen like that, and I want you to think of it as an error system where they're making the safest error possible. Okay, does that make sense? I know that's a little bit complicated. Any questions on that? Okay. So I'm just putting this up to refresh our memory. I know we looked at it the other day, but trauma alters the norepinephrine function in the locus ceruleus, the blue place. And you can see our little adrenaline faucet, just to remind you, and it squirts out all over the brain. So that's just kind of a handy thing to talk about with patients, the adrenaline faucet. You have one that before PTSD really only turned on when you needed it, and then it turned off right away. But since the trauma, it's running all the time. And when a scary thing does happen, it really flows, and it stays on longer, and it's harder to come back down to where it started. So this is a concept that patients pretty easily wrap their heads around, literally and figuratively. Okay? So it's just an easy way to talk to people. And then just reminding them that moral injury is a thing. It's real. And it's like having a bone in your body that's trust and somebody breaking it with betrayal. Another really easy concept to get across. Just one more tool in the toolbox. Okay? I'm trying to give you a bunch of things you can use in 5 minutes or less. So we're going to flip the script and do some cognitive restructuring. So when I say script, I mean like, when they write out the story for a play that actors read, that's what I'm talking about. We're going to switch it around. So usually not in the first appointment, but maybe in the second or third before we really start to do a lot of work, I'll say, maybe we ought to take a minute and just stop and thank the PTSD. And they say, why? I say, because it probably saved your life. And then they go, yeah, I was on guard, I moved quick, I slept with one eye open. Those things probably saved my life. Okay? So, thanking the PTSD. Dziękuję PTSD. It may have saved your life. Now we can make a decision on what we want to keep and what we want to try to remove. The things that you don't need anymore. The things that you needed in that context before that was so scary that you don't really need now in a safer place. Okay? If they're truly in danger, let them keep whatever defenses and resources they need to survive, especially if it's a domestic violence or someone going back to the front. We don't want to take away anything that's going to help them survive. Okay? So safety first. But now we can start to see what symptoms really, maybe we can start to work on. Okay? And I like to do this little trick where it takes guilt that over time, sometimes because they've done a guilty action over and over, or sometimes because it was so severe, it has become a shame to them. It goes from, I did this bad action, to I am a bad person, I am an evil person, or I am a monster for having done these things. You will see this in the context of war where people have killed. Okay, they feel very terrible for this. There's a difference between murder and manslaughter, but we'll talk about that another day. But guilt becomes shame in time. And what we want to do is we want to re-externalize it. It was an action of taking the cookie out of the cookie jar, and it was a bad thing to take the cookie, to I'm a bad girl for taking the cookie. But what I want to do is I want to re-externalize it back into regret. So I want to take it, move it back to, I feel guilty about this thing I did in the past. I regret it. Because that's no longer, I regret me. If I regret me, the solution is no more me. The solution is suicide, right? Shame leads to suicide. So if we could re-externalize the thing that they did into an action again, tell me about that day. What happened? And they say, I really regret it. We can say, okay, that's helpful information. Because that now identifies your values. Because you regret that, that shows me your values are the other thing, the other way to do it. And unfortunately, sadly, we can't fix the past. But what we can do is choose today to move in the direction that value points. And that can be really, really helpful. So sometimes when people have strong regrets, the action that's reparative is working in that same domain. For example, we had a very refractory PTSD residential clinic, and someone was very upset because in Vietnam he had killed a child. Didn't mean to, but the child was killed. And he said, I can't be around children, it's just too awful, I'm just a monster. But he was able to turn that into a deep regret, but then he ended up working with kids, reading to them, and that became restorative to him. So these are things to think about. This isn't necessarily something that's going to happen in a session. This is something you're going to work on for a while. But that's what you're listening for. What's good about the bad symptom? Sometimes when I have a patient who comes for 1, 2, 3 sessions, and they say, oh yeah, I want to start the medication, and they don't. They come in next time, I forgot, I don't know, maybe I do want to, but I didn't. And you get that kind of ambivalence. I like to flip the script here, and I say, why don't you tell me some good things about the PTSD, or about depression or anxiety or whatever it is. Tell me some good things. And they say, well, there aren't any good things about it. I say, I don't know, maybe. And they say, well, I mean, they kind of treat me with some honor because I'm a vet, or I get my, disability payment, or I can phrase it another way and say, what would it look like if you didn't have PTSD? What would your life be like? Oh, well, then I'd have a job, and I don't really want to have a job, so that you can get to where the resistance is. I'd have to be responsible. I would have to do this. I don't have, in some ways, maybe an excuse, so we can look at it that way. But it's how the patient's perceiving it is what's important. So this is a way to kind of sort through and find out where the barriers are, okay? Because that's what we're going to have to negotiate with them. Okay. Sometimes we get a little frustrated because nothing's happening. Nothing's moving. Is today the day for change? Maybe not. Even when the behavior doesn't change, it doesn't mean that the mind didn't change. So it takes a lot of time for us to put information in sometimes before we get movement. They have to think about it. It's got to ferment a little. I call it preparatory work for readiness. So I think of it like when you got those dishes that you didn't have time to do last night, and they sat overnight and they're kind of dry and stuck. I'm going to put them in the sink and let them soak for an hour. It's kind of what I think of with the patients. I'm just going to let you soak for an hour, loosen everything up. We'll come back next week or next month or whatever it is, And we'll see if maybe things loosen up and we can get going on some of this. So it's kind of how I think about it. So discussing post-traumatic growth, introducing the concept to patients. They know about PTSD, maybe. Let's talk about post-traumatic growth. Like I said, it doesn't end there, right? And you got to be careful here because you don't want to go, let's talk about all the good things that can happen because of your trauma. I'll phrase it more like, this is really hard, isn't fair. We didn't choose it, but here we are. So why don't we look at this as a chance to write a new ending? We just looked at this one, right? Chance to grow beyond our perspectives and limits. Use our meaning-making machine to make new meaning and see if it reduces symptoms. Okay? Recognizing and responding to unconscious transferences. So the 4 transference archetypes in PTSD. This is by Jonathan Shea in his 2015 paper, Moral Injury. He said the casting director has only given the patient with PTSD 4 characters in his script. The perpetrator, the victim, the bystander, and the rescuer. And we talked about this a little bit, how in each moment we can become one or the other. So I'm not going to go deeply into this, but I want to talk about it a little differently today. Again, we have these archetypes. They're going to project it onto you. Maybe one session they're going to be one way, or they might change every 5 minutes. I've had that happen before. It's a whirlwind. And remember what Freud said about this being our best instrument, the transference. The thing that we thought is the most destructive to treatment actually is our best tool. I still like my $1 million instrument. But we have to navigate this minefield with our patients, right? So they're going to throw up these transferences. And if they say, you're just going to hurt me like the last doctor, I can say something. If I see that this is a transference, right? I can see that it's the perpetrator transference. I can say, I'm really sorry that you were hurt like that. It sounds really awful. And I wouldn't want to do that to you. As a matter of fact, I'm going to do everything I can to not do that. If you think that's happening, let me know. So let's think of a plan where you feel safe and we can agree to do this together and you have some control about how we do this. Right? That kind of brings down that defense. If they say, oh, you don't really care, you're just a busy doctor, we're just another patient, just a number, you have so many other people to treat. I say, I'd really like to hear your story, and this is your time with me that's just for you. I'd actually like to do something with you. Let me give you some experience that I have and tell you about these options. And why don't we work on a plan together? They're like, oh, well, maybe you will do something for me. And the victim, you're just useless like me. You're just hurt as I am. I said, well, humans all are hurt in different ways. But that's led to some experience and some growth. Why don't we figure out if any of these things that I've experienced might be helpful for you, or we can get some other ideas about ways other people have done it. And then the rescuer. You're the only one that can help me. You have to save me. I'm in a terrible situation. We get that phone call every now and then, right, from a patient that you're the only one that can fix this. Limit setting is good here, but we tend to want to be rescuers, so we want to do this anyway. But it's good to set limits and to say, I'm here with you this hour this week. Most of the time, 99% of the time, you're going to be with you and I'm not there. So let's figure out ways that you can keep you safe. And if you need to contact me, these are the times you can do it, and I'll respond the next day. Some kind of limit like that. But it can help, and to say, what are the things that you can do here that I can support? So you make it where they have the primary role. Okay? So you have to see them, and once you see them, you have a countermeasure, and you can maneuver through this with them. Making the unconscious conscious, we just talked about this. I'm not going to spend much time. But again, it's the primary task, I think, of psychiatry, is to allow the opportunity for people to grow into a situation where they can see change in their life. Spinning the moral compass, the shoulda game, and the third chair. So we did the moral compass the other day, right? Remember, that was my patient that said, "Oh, doc, I'm full of shame and guilt." And I said, "Oh, good, we can get to work." So those are the things that identify value. You can work in those domains he called his dad. Remember talking about this the other day? Okay. So that's a quick technique that I can do in about 5 to 10 minutes. Another one is the should-have game. And you hear a lot, "Oh, I should be better than this by now," or "I shouldn't be so sick," or "I really should be doing this." I start to listen for shoulds, and I'm not sure what that word is in Ukrainian. What is it? What? Povina. Okay. So when you start to hear that povina a lot, I'm listening for that. My answer to that is, who said so? I should be better by now. Who said so? It seems to me you should be exactly where you are right now. That where you are is where you are. I should feel better. Who said so? So what you're really doing here is trying to unmask the unconscious rules and expectations that they've somehow gotten in their head, probably from childhood. And they hear this voice, this super ego, correcting them all the time. Right? So it is, remember we had talked before about the idealized self and the real self, and the distance between the two is where we find these stuck points. This is what we're trying to identify here. We're going to challenge those unconscious rules. Now the fun thing about this is you can do this in a group therapy. You get the whole group to play the shoulda game. So when someone's telling their story that day and they say, "I should this, I should that," and then the group says, "Who said so?" And they challenge them. And so now you get peer-to-peer interactions where they're catching each other and playing the game. You'll hear them on the unit, one guy walking through dinner saying something, "Oh, who said so?" You know, that's kind of fun. You can do it with husbands and wives. Sorry, I got excited. You can do this with husbands and wives. So a lot of my vets, if the wife is in session with them, I will say, "Why don't you try to catch him doing the shouldas?" And it'll be funny because they'll come in next time. "I caught him doing 17 shouldas the other day." And he's like, "Yeah, she did." But it really challenges, why do you think you have to be a different way than you are? It may be okay to just be where you are. Okay? And the other is the third chair. And I think my friend up there, this might answer some of your question too. So the third chair is a technique that I often use when there is a loss, when someone has a death that they're struggling with. Not necessarily for grief, but when I have a soldier or Navy, Air Force, whatever. When I have a soldier sitting with me who is really upset with himself, I did the wrong thing. I really messed up that day. It's all my fault. This is terrible. I should have been the one who died. Which we hear a lot. Say his brother is, I don't know, give me a male name. Andrei. So, hi Andrei. So if Andrei died, say in combat, and his friend was with him and feels guilty about that day, and is very hard on himself, I say, why don't we We literally pull a chair over. And I say, let's imagine this. This isn't magic or a seance. Let's imagine Andre is here with us. And I want you to tell me what Andre would have said about that day. And so the patient, from the voice of his friend, says, well, all right, who's the other guy? Give me another name. Yuri and Andre. Okay, so Yuri's the patient, and Andre says, in Yuri's voice, says, well, Yuri, we were really tired. We didn't sleep all night. It was terribly confusing. There was smoke. We got bad directions from our command. We didn't know what was going on. Man, you tried to save me. The patient can tell you that from an externalized third person, but they can't tell you that from themselves sometimes. So they can have compassion externalized from their friend to them, but they can't do the self-compassion. This is really tricky. So we're like, what would Andre say to you now about your life? Man, Yuri, you gotta go on and live. I can't live, but you can. Don't forget me, man. I love you, man, but you gotta live your life. So it's a very interesting technique that can be done. It allows you to tap into the patient's own knowledge about what his friend who loves him would have said to him. You can do this in lots of situations, but this is kind of specifically why we use it when someone is very tormented and their beloved other would give them different recommendations for their life than what the patient can say about themselves. That was a little complicated. Did that make sense? You have any questions about that one? I usually have a fairly good rapport with the patient to do this. I might not do this immediately with someone I didn't know, but maybe. I have 28 seconds left. You can do it. The language of supportive therapy. So these are phrases. I'm going to take the liberty of 5 minutes. The language of supportive therapy. These are phrasings that we can use to improve the alliance with the patient. So I'm going to give you some examples. Reassurance or encouragement. I know it's hard coming into the clinic today. I really appreciate that you put the effort in. I think it's going to get easier over time. Okay. Normalizing. A lot of people tell me that they have situations where sometimes they have flashbacks. I'm wondering if something like that occurs to you. So I've started with most people say, or some people say, a lot of people tell me, I've heard before. It means this isn't the first time I'm hearing this, and I'm not going to think you're crazy. I'm normalizing the behavior. It happens. Advice and teaching. This is what we know about PTSD. It can have flashbacks. It can have depression. It can have changes in mood. It can have, hypervigilance and high startle. Let's learn about it a little bit so we know what to call it if you notice any of these things. Anticipatory guidance. You may have a difficult day one of these days, and if you do, what are some things you could do to help you feel better? So I'm anticipating a situation in the future and already giving guidance about how to manage it instead of waiting for it to happen. Praise is easy. Great job coming in today. Thanks for putting in the effort. I appreciate you. Naming the problem. Wow, everything you're telling me sounds a lot like depression. Have you heard of that before? What do you know about depression? Or that sounds like moral injury. I use that one all the time. That sounds like moral injury. Maybe we could use that term for it. Clarification. So you told me that you were having trouble sleeping at night and having some bad dreams. I just want to check, is that what you meant? Were they nightmares? Could you just give me a little more information on that and clarify? Reframing. Is it possible that instead of being the one responsible for your friend's death, actually you tried everything in your power to save his life? And I've reframed it. Okay? Confrontation and interpretation. Confrontation. You said that you're feeling fine, but you just told me you're having trouble sleeping and your wife is about to divorce you and you're having trouble feeling like getting up to go to work. I'm wondering if that's really fine. Or maybe there is something here that we could work on. So I'm kind of confronting them. I'm directly saying, you told me this, and I'm going, maybe not. Okay? You don't want to do it too hard. You're going to be like, oh, you're lying. An interpretation. I have to think about this one for a second. I've noticed that you've been 5 or 10 minutes late to our appointments for the last few weeks. Right before that, we were talking about some difficult stuff that we were working on. I'm thinking that maybe they're related, that it got really hard to talk about this, and maybe not coming in, even though I know you're busy and time is tight, might actually be because it's really hard to get in here and deal with that. So I'm speculating, I'm making a guess and interpreting something in another way. So using this passive voice, I was wondering if it can be really helpful. It's non-judgmental. It doesn't sound like I'm accusing anyone of anything. So that's something that can be helpful just in general, speaking with people, but specifically your patients. Any questions on those? Yes.
Can you share the confrontation examples and how far the confrontation can go for your experience?
How far can the confrontation go? It depends on your relationship with your patient. So there are some I'm going to be extremely gentle and I might not do it at all because they might get very angry and storm out of the room. And there are some that we have a good rapport in 5 years of work together, and I go, I know better than that because you've been telling me for 2 years it's this other way, and now you're saying this. So it depends on the rapport with the patient and your relationship. Okay? It's going to be individual. All right. Any other questions? Summarizing is just going to repeat what I've just told you. And my final thoughts to you. Change is possible. And, we got a question.
Я хотів спитатись стосовно терапії з третім стільцем. Чи бувало у вас випадки, коли вона йшла не по плану, і коли людина в цьому уявному друзі ще більше себе картала? Чи вона завжди йде плюс-мінус за таким сценарієм, як ви описали?
I've never had it go really badly. I think I've had it where it wasn't as impactful as I hoped, but we still got a little bit of it. But usually, I can steer it in that direction enough that we kind of end up with that information. You just have to do it very gently. Okay? It usually works reasonably well. You have to pick your moment. You have to kind of know when you're ripe and ready for that. Okay. So I just want to say, change is possible. Remember, that's sort of our primary reason we're doing this. Monitor for isolation, keep them in community. And in Latin, compassion means to suffer with. I find it a great honor to sit with our patients and share their suffering, which lessens it for them. And you are resilient, valued, and appreciated, all of you. Don't doubt that. And I just want to say thank you for your kind attention. This is my last lecture. And Slava Ukraini.